So I think we are going to get started now. It's really a pleasure for me to have a gastroenterologist here. I mean, you know, back in the day, so when I was still in Minnesota, when we found the gene that causes myotonic dystrophy type 2, one of the ways we determined whether or not people were affected was to ask about how their bowels were working. I mean, you know, because it's pretty reliable that it's a feature of this disorder. And so it really was a big topic. If you look at all of the meetings of the Myotonic Dystrophy Foundation, way at the beginning, we had one in Minnesota. And I, unfortunately, was the gastroenterologist at that meeting because I couldn't find any gastroenterologists. Back in the day, we would send people to gastroenterology and they would get scoped from the top and scoped from the bottom and told that they couldn't find anything. And there wasn't a whole lot more that we could do. And so it really was a puzzle and a real delight for me when I moved to Stanford to find out that they actually had an entire group in gastroenterology that was focused not on structural problems that you would necessarily identify by scoping, but on functional issues. You know, what makes the bowel not work right, the motility group. And so it really has been a joy and pleasure and very intellectually stimulating to work with the Motility Center at Stanford. And so it's really my pleasure to introduce Dr. Irene Sonu, who is going to bring us all up to date on kind of where we're at and understanding the effects of myotonic dystrophy on the bowel. So thank you so much for being here.
Thank you. It really is a distinct pleasure to be here. And I welcome any questions that you have. And I want to provide you all with a very comprehensive overview of how our GI tracts work and what happens when there is a motility or digestion issue. And, you know, as Dr. Day had mentioned, we have this robust group of specialists called neurogastroenterologists that are GI trained, but we focus primarily on this issue. So I welcome any questions that you have. And I hope I didn't jam pack this too much so that there's ample time to answer any of those questions. So let's go ahead and get started. All right, so although there are limited numbers of published studies investigating GI conditions in DM2, what we do know is that GI symptoms are incredibly common. And there is this registry that has been following patients with DM1 and DM2 for a very long period of time. And about 6 years ago, they published this paper really looking at the gastrointestinal manifestations that occur in both types. And there were a total of 180 DM2 patients that were included in this registry. And it really helped shed a lot of light as to what patients are experiencing. And so this long-term data primarily, a cohort of patients primarily focused, enrolled patients that were older. So just want to throw that out there, that most of the information that I'm going to provide you in the next few slides involves mostly an older population of DM2 patients. So it's less clear how common GI symptoms are in younger patients with DM2. But what I did learn from this study is that over 3/4 of patients with DM2 have at least one GI symptoms, but none of the patients in this registry actually develop GI symptoms as their initial presentation of their disease. It usually manifested over time. What's more perplexing is that we don't really know why, the exact reason why their GI symptoms are so common. The physiological mechanisms, meaning what the underlying causes, it's much more unclear, and there's a lot of room to perform more research on this topic. But what is thought is to be going on is, of course, some underlying muscle weakness and dysfunction that's involving the smooth muscle of the gastrointestinal tract. But there's also thought that there's more to just muscular function that's playing a role here, or dysfunction. It's also thought there's a lot of nerve damage or nerve abnormalities that's contributing to these gastrointestinal symptoms. And there may also be a hormonal role playing here. So this is an image of what a part of our GI tract looks like on the left. And then you can see here on the right, what our gastrointestinal tract is comprised of. But I just wanted to illustrate to you what the muscle layers of the GI tract do on a daily basis to help pump what we had just eaten for lunch today down through our GI tract. So there's two different types of muscle. There's this circular muscle that just basically squeezes and makes the lumen, the inside of our tract smaller. And then there's this longitudinal muscle that kind of shortens, kind of like an inchworm. And so there's a coordinated movement between the circular muscle and the longitudinal muscle that allows for motility, or what we call peristalsis, to occur on a daily basis. And so this basically propels or pushes, the digested food that we eat down our gastrointestinal tract. So it starts off with, of course, our mouths, moving on to the esophagus, the stomach, and then we have our small intestine, and then the large intestine that ends with the rectum and the anus. And so the beginning of our GI tracts are what we consider to be more receptive organs, right? So they collect what we're eating. And then the small and large intestine are really responsible for absorbing and digesting and providing us with all of those, micro and macronutrients that we need on a daily basis. But in order for this to happen, we also need to have an intact nervous system. And the GI tract is very unique in that it has its own nervous system. We call it the little brain of our body. So it's called the enteric nervous system. And it's controlled, it's very nuanced and complicated, but there is a primary driver within our brains called the autonomic nervous system that helps kind of allows for the enteric nervous system to function on a daily basis. And so you may remember from back in our biology days in high school that we have something called the sympathetic nervous system and the parasympathetic nervous system. So our sympathetic nervous systems respond to stress. It's like as if, let's say we're getting chased by a bear. And during that stress response, there's decreased digestion because that's not a priority when you're getting chased by a bear, right? When you're under just distress. And then to complement that, we have our parasympathetic nervous system, and we call that the rest and digest portion of our gastrointestinal tract. That's what we want to be activated whenever we're digesting. So you can have derangements in either part of your nervous system when you develop gastrointestinal symptoms. You could have too much sympathetic drive or too little parasympathetic drive, and it's that imbalance that can really contribute to the onset of GI disease. So you'll see here on the right of the slide, though, that there's a lot of symptoms that are associated with the individual gastrointestinal organs here, right? So you see esophagus, they talk about dysphagia and aspiration. And so the goal of this talk is to really basically describe everything that's outlined here on the right, okay? So I'm going to start from the top and end with the end, or end with our bottoms. Before I do that, though, I want to refer back to that study that I talked about, that registry of 180 DM2 patients. And what was very interesting was that the symptoms that were the most common in DM2 patients, which are outlined here on this graph in yellow, DM1's in blue and DM2's in yellow, the most common was constipation. And then second to that was acid reflux. And then after that was trouble swallowing, otherwise known as dysphagia. You'll hear me using that term a lot. And then after that, you get gallbladder problems, liver problems, and stomach ulcers. So more or less every single gastrointestinal organ may be involved in the development of these GI symptoms. What I also found to be interesting in that study was that over a long period of time, so they followed these patients for 5 years, is that it was common to develop these symptoms over time. So the column on the right that I've highlighted here in green, and you'll see in parentheses, those numbers in parentheses represent percentages. though that represents a percentage of patients that when they first enrolled in the registry, they didn't have any GI symptoms. And then over time, they went on to develop them. And so the most common new symptom that developed over that 5-year period, again, was constipation, trouble swallowing, and then acid reflux. This was a much older and much smaller study, but the reason why I wanted to include this was that this study asked about 30 DM2 patients about what their primary symptoms were. And again, constipation and trouble swallowing were the most common, were very common, but third was abdominal pain. And so that was not actually mentioned in that registry study. And as to why people are getting abdominal pain, that's more complicated, but I'm going to try to get into that more as I kind of discuss the various conditions that affect the GI tract. But last but not least, I just wanted to mention here that the vast minority of patients with GI symptoms are actually on medications for their GI symptoms, even though they're obviously experiencing them. And as to why the vast minority are not on therapy, vast minority are on therapy, that I don't have a good answer to. Is it because they're not mentioning it to their doctors, or their doctors are not taking their symptoms seriously, or not prescribing it, prescribing them anything for their conditions? Or maybe their symptoms are mild and don't require a lot of medication. So I don't have a good answer as to why so few people are actually on therapy. But I'm hoping one of my take homes from this talk is that there are so many ways that we can help these symptoms. I hope that this really provides you with some education of what we can do to get you feeling better. All right, so I'm going to start off with the esophagus, and then, like I said, make my way down the gastrointestinal tract. And so, as I mentioned earlier, dysphagia is otherwise known as difficulty swallowing. And so, what people you will usually say is they have a feeling of food not going down the right pipe and they're choking. They may be coughing whenever they swallow, or they may have frank aspiration, meaning getting liquid and food down their windpipe and into their lungs. And when a significant amount of that gets into their lungs, then that can turn into an infection. And that's called an aspiration pneumonia. In addition to having difficulty, patients can say they're regurgitating food. It doesn't go down all the way, so they're bringing it back up immediately. They'll have discomfort, or they constantly have to chase food with water in order to bring it down. And in addition to having a dysphagia, it's really common to also mention that there's heartburn. So heartburn, acid reflux, gastroesophageal reflux disease, GERD, all the same thing. And what that essentially is where acid goes up from the stomach up into the esophagus, and that can cause a lot of discomfort. So it's not uncommon to have both dysphagia and acid reflux at the same time. And so what part of the swallow is affected in DM2? So we don't really know, but I want to explain that there's actually two parts of the swallow that we always focus on. There's the first stage of the swallow, and that's called the oropharyngeal phase. And what that is, you see here an image of basically a person swallowing this yellow bolus here. And during that oropharyngeal phase, most of us don't think about it, right? But we push our tongues against the top of our mouths, our hard palate, and that brings the food back. And then you have these protective kind of ways to prevent food from going up into your nose and then going down your windpipe. You have your epiglottis, for example, that will shut your windpipe down so that food will just seamlessly go down into your esophagus. So the oropharyngeal phase is what we consider to be the first phase, and it's a voluntary movement, right? And it requires a lot of neuromuscular coordination. The second phase is called the esophageal phase, and this is kind of on autopilot. It's what is kind of considered to be an involuntary movement of your esophagus. So as soon as something arrives, liquid or food arrives into your esophagus, then your esophagus reflexively will relax. So you have these sphincters, which are basically these tight muscles at the top and the bottom of your esophagus that reflexively should open up and relax. And then you have your esophagus pumping down that food and peristalsing. And so this is all controlled by your, by the swallowing center of your brain called the medulla. And when you have normal motility, then the moment something lands in your esophagus, then there should be the seamless coordination of the sphincters opening up and food getting pumped down into your stomach. So we actually don't know how frequent or which type of the swallow in DM2 is more frequently affected. What we do know is based on very small, very limited data that either phase, the first oropharyngeal phase or the esophagus phase, can be affected. I just don't know which one's more common, but I know that in DM1 that the first phase, the oropharyngeal phase, tends to be more common. But yeah, there's very limited research as to what exactly is going on, if whether or not it's both or just one or the two phases that's impaired. But I'm not going to go into deep length, but there are a number of different types of esophageal motility disorders that can come into play here, where, for example, there's one called ineffective esophageal motility, where the esophagus walls have weakened and it no longer pumps the food down easily. And so that's something that I have seen in my DM patients. I just don't know how frequently it's seen overall in DM patients, but there are a large variety of motility disorders of the esophagus that could potentially occur. And then with that first phase, the oropharyngeal phase, the most likely cause of impairment there is primarily neuromuscular weakness, as I mentioned earlier. So how do we go about working up a patient who presents to you who presents to me in clinic? So I always really focus on the two phases. So I always ask, are you having trouble transferring the food down? Do you feel like you're choking a lot? Is it hard to bring it down? Or do you feel like it's getting more stuck further down, like in your neck or in your chest? And so based on what my patients explain to me, then that will determine what the next steps are diagnostically. So when you're focused mostly on the beginning phase of the swallow, then the two studies that I've illustrated here are what I usually order. So these are usually done by a speech therapist. And the most common one is the one on the left. It's called a modified barium swallow study, where a speech therapist will have you swallow different thicknesses of liquids and solids, and then they take pictures with an X-ray, see if any of that is going into your windpipe. The FEES study out there on the right is oftentimes performed by either a speech therapist or an ear, nose, and throat doctor, where they take a tiny little scope, they put it down your nose, and then they look at your vocal cords, and they look right at your windpipe, and they see, as you're swallowing different substances, they'll see if any of that gets into your windpipe. So two kind of complementary tests that are used all the time to evaluate the beginning of the swallow. The esophageal phase of the swallow, that's where I come into play. So I spend a lot of my time doing upper endoscopies, that camera study where I take a look and I see if there's anything abnormal. That doesn't necessarily evaluate motility as well. It's looking for more structural issues. If I see a narrowing, if I see really bad esophagitis, meaning inflammation from heartburn, and that can shed light as to what's going on. But to really evaluate the muscle function or the motility of the esophagus, the best test is what's illustrated on the right. That's a picture of something called an esophageal manometry. And that involves actually a catheter, like a little thin wire going down your nose while you're fully awake and you have to swallow it. So it's not the most comfortable test, but it provides a plethora of information for us, because while that catheter is in there, it has pressure sensors and you swallow water. And I look at how your sphincters are functioning, and it's a really nice way to get a global assessment of your esophageal functioning. On the left here is an X-ray, and again, we use this as more of a complementary test. We oftentimes end up ordering all three of these tests for our patients, especially if we don't know what's going on But the barium esophagram, thankfully, is a lot easier to handle. It involves you swallowing some liquid contrast, and then the radiologist will take a bunch of pictures as that contrast goes down your esophagus. So how do we treat dysphagia? Of course, it really depends on what's causing the dysphagia. And that's why diagnostic testing is so important, because it really can help determine what the next steps are. And if it's mostly an oropharyngeal, meaning that first phase of the esophageal swallow is abnormal, then that's where speech therapy and dietary changes are of utmost importance. Whereas if it's more down in your esophagus, then it really depends on what's going on. If there's a motility disorder, then sometimes we'll use medication to help relax the esophagus a little bit better, or we'll try to put patients on acid reflux medication, because if we are worried that acid reflux is actually causing muscle motility disorders. If things are too tight, we actually try to relax them by injecting Botox into the esophagus. So, there's a lot of options. It really depends on what the underlying cause is. In more advanced cases where, if we really tried all of, different medications and interventions, and patients are still really at risk of aspirating, getting a lot of their food in their lungs, then of course there has to be a discussion about whether or not there's any benefit to getting a feeding tube in the stomach. So moving on, I want to touch upon reflux because, as I mentioned, this is a very common condition that affects DM2 patients. And as I mentioned, what it is where acid goes up into your esophagus from your stomach. And so the most common symptom is heartburn. You get that kind of chest discomfort after your meals, or it wakes you up in the middle of the night. But you could also get acid regurgitating up, and you can even taste acid. Sometimes people will say they wake up and they get that taste of metallic taste in the morning. And as I mentioned earlier, you can also get that difficulty swallowing alongside those classic symptoms of reflux. What's less common, but of course we still see this a lot in our practice, is that in GI clinic or having chest pain, coughing, something called globus sensation, where you feel like there's a fullness in your neck all the time. Some people will come back and say that some people will see their dentist, and they'll come back to me and say, my dentist thinks there's acid eroding all my dental enamel. They think it's reflux. So that's another sign that there may be poorly controlled reflux going on, as well as some laryngitis. So the most common cause of reflux is that the sphincter, that muscle that I was telling you about at the bottom of your esophagus, is opening up and relaxing all the time. And that can be from a variety of reasons. It could be from smooth muscle damage. It could be from weight gain, where you have a lot of pressure pushing on the sphincter and opens up more easily. You could have something called a hiatal hernia, which I've illustrated here on the right, where normally the sphincter should align with your breathing muscle, your diaphragm. But sometimes as you get older, your diaphragm can weaken, or just from changes to your weight, or just life in and of itself can lend your diaphragm to get a little bit weaker. And then you have what we call herniation, or movement of your esophagus, such that you have some stomach now above your diaphragm, and you no longer have the help of that diaphragm muscle to keep your esophageal sphincter closed. And so it's much easier for it to open up and allow acid and other things to go up into your esophagus. You could also get reflux because you have an underlying motility disorder, as I mentioned, weight gain, central fat, like the fat around your abdomen can really put a lot of pressure on your stomach. And but then a lot of the time it's as a result of treatments that patients undergo, such as medications. And so it's always really important to do a thorough medication eval to make sure that patients are not on something that decreases how much saliva you make, because saliva helps clear away acid. So it's really important to make a lot of saliva to wash away that acid. So how do we diagnose reflux? So, endoscopy, as I mentioned earlier, is done all the time by gastroenterologists because they're so helpful in identifying certain diseases. And the picture on the left is a patient with really severe esophagitis. So you see those red lines going across. So that's abnormal, and that's very angry, inflamed esophagitis. And I know it's hard to appreciate on this image without a normal esophagus next to it, but the damage has also narrowed down the esophagus and resulted in something called a stricture, where the esophagus is much smaller now because of all that untreated inflammation. Fortunately, the majority of people that we scope do not have any severe damage like this. And so then how do we get to the diagnosis of reflux? So on the right here is someone undergoing 24-hour pH testing. Again, it's not the most comfortable test, but there are other modalities that we offer our patients that don't involve a catheter that essentially will measure how much acid is going up into the esophagus for a 1 to 4 day period. And that will help give us a quantitative measurement of your acid reflux burden. So in terms of treatment, there's thankfully a lot of wonderful, effective medications. And actually, the majority of them are over the counter now, which is great. And the majority of them are also pretty inexpensive. But first and foremost, I always talk about lifestyle. So diet can play a huge role. I think a lot of us eat a really nice big dinner because it's like a social convention, but our motility, our digestion is actually the slowest at night. And so we really should be reversing things and eating a bigger breakfast if you want to make one meal bigger, and eating a really small dinner. And so diet can play a huge role in it's not only important to focus on the size of your meals, but the content of your meals. So a lot of people get worsened reflux if they're ingesting a lot of acidic foods. So some of the common culprits are citrus, unfortunately chocolate, and tomatoes. But alcohol also is a very common trigger because it actually it relaxes your sphincter. It's a smooth muscle relaxant of your esophagus. And so that puts you at risk of more reflux. So a lot of the time you can make some simple dietary changes. If you've gained a lot of weight loss can make a huge, huge difference. And then if you have a lot of nighttime symptoms, I highly recommend sleeping with a wedge pillow. So studies have shown is that sleeping elevated at least 30 degrees, ideally more than that, 45 degrees. And, thankfully it's really easy to buy a wedge pillow, or, there's a lot of those elevated like Sleep Number type beds that are available now. But in addition to sleeping elevated, studies have shown that sleeping on the left side, actually, for me, it's a little bit counterintuitive because your stomach empties out to the right side, but sleeping on your left is actually better for you for reflux at night. So elevated and to the left really helps. If lifestyle measures don't help enough, then that's where medications come into play. And the best medications are PPIs. And I think they get a bad rap because there's a lot of media coverage. Oh, they cause dementia, they cause, kidney damage, electrolyte damage. Actually, there's been really no good studies to prove that these medications are harmful. And in fact, there was a really nicely done randomized controlled trial showing that these medications are safe. And so it provides me the reassurance that I can provide to my patients that it's okay to be on these, even if you have to be on them long term. But you may be familiar with omeprazole, which is otherwise known as Prilosec, or esomeprazole, which is known as Nexium. Remember the purple pill campaign? So these medications are all over the counter. And then if you need a higher dose, then your doctor can prescribe you a higher dose of them. But they are the best drugs we have in the market. 60 to 90% of people with true reflux are going to benefit. So they're really, really effective. If you have more mild reflux, then you don't necessarily have to jump to a PPI. You could try something called a histamine 2 receptor antagonist. And that's basically an antihistamine that partially, not fully, lowers how much acid your stomach makes. And that's what all these medications essentially try to do, is try to lower how much acid that your stomach makes. Because unfortunately, there's no good way from a medication standpoint that we can try to decrease how often that sphincter opens up. So all of our therapies are mostly directed at how much acid your stomach is making. But famotidine is very popular. It's otherwise known as Pepcid. Zantac was also a really popular brand before it came off the market. But those are another kind of great drug class of drugs, but they're just not as potent or strong as the PPIs. Last but not least are the antacids, and they're definitely the weakest of them all, but they're the fastest. The other two, the PPIs and the antihistamines, are very slow acting. So you can't take them as soon as you feel the symptoms. You really have to take them preemptively. So you're not going to necessarily feel better after just one dose, of Pepcid. You really got to take it, before your meal on a regular basis. Whereas the antacids, even though they're not as strong, they essentially are trying to neutralize the acid that you just ingest that's in your stomach. So you may be familiar with calcium carbonate, which is Tums. My favorite is actually sodium alginate. You can only really buy this online, but it's used actually naturally in cooking all the time. It's naturally derived from seaweed, and it's been studied in reflux to create a nice barrier. So you can take it after your meals, and then it blocks any food or acid from going up into your esophagus. Lastly is aluminum hydroxide, which is otherwise known as Maalox or Mylanta. Again, not super strong, but it can help some people, and they're very fast acting. In those that don't tolerate medications, or the medications are not effective enough, then surgery may be of benefit. I tend to not really be a pro-surgery kind of doctor, but in some circumstances, for example, if you have a huge hiatal hernia, surgery may be beneficial. All right. So next, I'm going to move on to your gallbladder. And what's been shown in studies is that patients with DM2 and DM1 actually get their gallbladder removed, or what's called a cholecystectomy, more often than the general population. The thought is that it's because the gallbladder is not contracting as much. Again, this is us hypothesizing because we don't really have a lot of robust research. But that can lead to gallstones forming. And when stones form and they cause an obstruction in your gallbladder, then that can cause an infection. And then you have to get your gallbladder out. And so the most common symptoms are having pain after a fatty meal in the right upper quadrant of your abdomen. And then when you have an infection, then you'll get a fever as well. But the way that gallstones or gallbladder disease is typically diagnosed is with an ultrasound, or CTs or MRIs are also just as good, but ultrasounds are very good and not pretty fast. And then treatment, of course, is getting your gallbladder out. So I was just chatting with one of the members here about gastroparesis, because we actually don't know how prevalent gastroparesis is in DM2, but I think it's because we're not looking for this often enough. But what gastroparesis essentially is delayed stomach emptying. Your stomach is moving very slowly, such that food is sitting in your stomach for hours, sometimes even for days. So the most common symptoms associated with gastroparesis are nausea, vomiting, fullness, bloating, distension, where some people will describe themselves as looking as if they're pregnant, early satiety. Just after a few bites of food, you get extremely full, abdominal pain, and then weight loss because you can't really eat much because of your symptoms. So how do we diagnose gastroparesis? The most common way is the way on the left. It's called a gastric emptying scan or gastric scintigraphy. It does involve some radiation, but it's non-invasive, which is nice. But what it involves is you eat a small meal of eggs and toast that has a tracer in it. And then the radiologist will trace how long that food is in your stomach. So if after 4 hours, there's still a lot of that meal left in your stomach, then that's positive. That means you have gastroparesis. A newer technology that we use all the time is something called Smart Pill. And that's a pill that actually it's a pH sensor that can detect how long the pill has been in your stomach, in your small intestine, and in your colon. And so if the pill is it's a great way to kind of globally measure how long your transit times are and see if any parts of your GI tract are moving slowly or not. So when we find gastroparesis in patients, the first thing we do is change the diet. Thankfully, a lot of patients feel so much better with just dietary changes alone. But what's essential is not eating big meals. That's kind of a mantra on GI, actually, is that big meals are not good for you for most things. But so instead of eating 3 large meals a day, small meals 5 to 6 times a day, you may even want to alternate between liquid and solid meals, because liquids don't rely on your stomach to have to break down that food. And so it empties so much easier than solid foods. The other a dietary change that's really helpful is to minimize fat and fiber. And I'm not saying cut out fat and fiber completely. I'm just saying try to eat it in low quantities. And if you're going to eat more, then eat it more in a smoothie or low particle form. Because again, it's just easier for it to empty out of your stomach if it's in a smoothie or liquid form compared to in a solid form. Otherwise, it's just going to sit there for a very long time in your stomach. There are lots of medications now that help enhance the emptying or the movement and the digestion of your stomach. So I use a lot of, they're called prokinetics. So I use a lot of prokinetics in my practice, as well as anti-nausea medication for people that have medication. But there are some newer technologies. There are surgeries that we perform a lot at Stanford, something called a pyloromyotomy that can really help, especially with the nausea and the fullness symptoms. And at Stanford, there are a lot of centers all over the country that also implant something called a gastric electrical stimulator to help with really severe nausea associated with gastroparesis. So moving on, gastroparesis is when your stomach moves slowly. What is it called when your small intestine moves slowly? It's called chronic intestinal pseudoobstruction, CIPO. More simply, I just call it small intestinal dysmotility. And so this, again, can be, I think it's probably underreported because it's being underdiagnosed, and we don't really know how common it is in DM2. But it can look very similar to something called a small bowel obstruction, and that's much different than SIBO. SIBO is where your small intestine is not digesting food very well. And as a result, since it's not moving very well, the small bowel walls will stretch out, or they'll dilate, and they'll look really big on imaging. Whereas when you have an obstruction, there's something that's actually basically cutting off flow or wrapping around your small intestine so that your small intestine is physically obstructed. But they can look very similar on imaging. And so the reason why I mentioned that is that a lot of surgeons or doctors will misdiagnose patients, DM patients, with a small bowel obstruction and send them to the OR for surgery, only to find that there's no frank obstruction. And instead of them actually having a obstruction, they actually have SIBO, this chronic intestinal pseudoobstruction. The symptoms are very similar, very, very similar to gastroparesis. But because your small intestine plays such an essential role in absorption and digestion of everything you eat, the consequences are usually malabsorption when SIBO is pretty advanced. So as I alluded to, the way that's diagnosed is usually with imaging. You'll see these stretched out walls of your intestines. So you can see that on essentially any kind of imaging, X-ray, barium study, or CT scan. I mentioned that smart pill study. That's a great way to kind of measure how slowly or how quickly your small intestines working. And then there's something called scintigraphy, which is very similar to that gastric emptying scan I mentioned. So treatment, first and foremost, if possible, is avoid surgery, right? And then very similar to gastroparesis, we try to make as many changes as we can to the diet to allow the patients to be able to tolerate food without a lot of symptoms. Oftentimes, though, especially if the SIBO is pretty severe, and there's evidence of malabsorption, then patients may require a long-term IV to get IV hydration or IV nutrition, which is also known as TPN, total parenteral nutrition. Another consequence of SIBO is something called SIBO, S-I-B-O, small intestinal bacterial overgrowth. It's not an infection, but it's where you get too much bacteria hanging out in your small intestine. So you have this microbiome in your body, but most of that should be housed in your large intestine, in your colon. But when you have too much in your small intestine, then that could lead to malabsorption. The symptoms are primarily bloating, distension, gas, and diarrhea, but you can also get constipation as well. So we try to treat that pretty aggressively in our SIBO patients, as well as prescribe medications that help those prokinetics that I talked about that enhance digestion. So, I talked about abdominal pain being common, right? That graph showed that over 60% of patients experience abdominal pain. And one reason why they may be experiencing pain is because they have something called irritable bowel syndrome. And, unlike SIBO and gastroparesis, which are relatively uncommon, IBS is incredibly common. It affects over 40 million Americans. And so it's just common across the board. What it is where people will experience abdominal pain that's associated with a change of your bowel habits. It can be constipation, it could be diarrhea, or a mixture of both. And it's very frequently associated with bloating, distension, and gas. You see here on the right, my favorite picture. As a gastroenterologist, I feel like I should have this tattooed on me at this point, but this is something called the Bristol Stool Scale, which illustrates what your poop should look like, right? So when you have diarrhea, you think about the higher numbers. They're more watery, they're more fluffy. So it's usually more of a tip, like a type 6 or 7. When you have constipation, there can be hard little pellets. So, don't be surprised if you see gastroenterologists and they pull out this picture or they just ask you straight up, what do your stools look like? It can be really helpful to figure out what kind of IBS you may have. So let's talk a little bit about constipation. So, IBS constipation is incredibly common, and it's not only about what your poop looks like and how infrequently you go. So by infrequent, I mean usually less than 3 bowel movements per week, but it's also about what you're doing on the toilet. Do you feel like you're straining a lot? Are you on the toilet for a very long time? Do you feel like you're having difficulty evacuating that stool? So that's why we always literally try, get to the bottom of things when we see patients in clinic and ask you all these questions, because it's incredibly important to know. Because some people will say, oh, I'm not constipated, I poop every day. But then when I ask them, what does it look like? They say, oh, it's like 3 little pellets per day. Then yeah, you're constipated, right? So what causes it? And, the thought is that, especially in DM, is your colon is moving very slowly. So simply put, that's called slow colonic transit. And we can do testing for that. There's something called a Spitz marker study, where you swallow a pill that has these markers in it. You can see those little white, kind of little beaded thick things on the right here on that X-ray. So essentially what happens is you swallow this capsule that has these radiolucent markers. And if after 5 days, there's still a lot of those markers left in your colon, that means you're moving slowly, because you normally, you should be evacuating something that you've eaten about 70 hours after you've ingested it. So 5 days later, it's still in there. That means your colon is likely moving slow. And then you can also use that smart pill technology that I mentioned to measure your colonic transit. But in addition to your colon moving slow, what's also incredibly common is something called pelvic floor dysfunction. So what that is that you lose the coordination of your muscles inside your pelvis. So normally, every time we need a poo, you should have your pelvic muscles should relax. And so this image on the right kind of shows the sling muscle that's wrapping around your rectum and your anus. And that sling muscle should relax. And that actually straightens out your colon and your rectum so that poop can seamlessly exit out, as your anus also seamlessly should be relaxing. And so pelvic floor dysfunction is incredibly common, especially in women. And what happens is that you lose that coordination. You're unable to relax enough, or you may even be tightening things up. That's called dyssynergia. And so I liken it to having a toothpaste bottle with the cap on. You're trying to squeeze that toothpaste out, but if you don't release that cap, then there's going to be no flow, right? So that's essentially what's happening in pelvic floor dysfunction. The good news is there are diagnostic tools. The bad news is that they are invasive, right? So we do a lot of testing to look for pelvic floor dysfunction, but it does involve catheters going up your bottom or injecting dye up your bottom and going under an MRI scanner and stuff like that. But the good news is that when we identify pelvic floor dysfunction, 80+% of people get better with a course of physical therapy. It's called pelvic floor physical therapy. And I also want to mention that your pelvic floor is not only responsible for pooping, for defecation, but it's also responsible for urination. So if in people that have both urinary and defecatory or defecation issues, physical therapy can help kill two birds with one stone and help with both of those symptoms. So it can be a real game changer. In addition to physical therapy, of course, I always want to make sure patients are moving around and exercising as much as you can. I'm not saying you have to go and do something rigorous. Even yoga can be helpful in helping you poop because you're enhancing that parasympathetic nervous system, that rest and digest portion of your nervous system. If it was as simple as hydration and fiber and going on walks every day, then my job would be a lot easier. But you have to find ways to try to relax that nervous system to allow your motility to activate, right? So exercise in any form, hydration, and then one of my favorite things is a squatty potty. So one thing that has really contributed to pelvic floor dysfunction is the invention of the Western toilet. In countries that still squat to defecate most of the time, they don't have as much pelvic floor dysfunction because we need our legs up, our knees up. We need to be in a squatting position in order to create that better angle such that your rectum is straighter and your sigmoid colon is straighter. And so for people that are short like me, the squatty potty can really help because it literally just elevates your knees and your legs so that you're in a more of a squatting position on the Western toilet. You don't need to buy the squatty potty. You could use books. You could use whatever you have at home to try to elevate those knees. So if you Google squatty potty, though, you'll see that it's very popular and it comes in many forms, even in a travel size. So they're really great. All right, sorry. And I want to talk about fiber because in America, we are at a fiber deficit. So majority of Americans only eat about 14 grams of fiber. We recommend 25 to 35 grams of fiber. So I think the reason why so many Americans alone are just so constipated or just so irregular is because we're just not eating enough fiber. But fiber can be really irritating, especially in patients that have IBS. It can cause a lot of bloating, gas, and pain. So what I usually encourage patients to do is buy a soluble fiber supplement. I'm a huge fan of them. And most of them come in a powder form and they make you drink more water too. So it keeps you hydrated, but they're so much gentler on your gut. So it's less bloating, less that pain. So those are the three. There are my three favorite brands. So you may be familiar with psyllium husk. It's also known as Metamucil. I personally take wheat dextrin. That's Benefiber. And then methylcellulose is Citracel, but they all are wonderful. I usually tell most of my patients to steer away from insoluble fiber, like all bran, Fiber One bars, all of that, because they're very irritating. And actually studies have shown that they can increase pain. So you really want to stick with the soluble. And soluble is great for not only just constipation, but it actually creates a more formed stool. So I use it in all my patients with diarrhea as well. I also want to acquaint you with some laxatives. So when fiber, exercise, all those lifestyle changes don't cut it, then you want to go straight to laxatives. Unfortunately, laxatives, for the most part, are inexpensive and very easy to access. Most pharmacies and grocery stores will carry them. So I'm not going to go through each one at length, but you'll see that there's just a variety. But just want to throw that out there, that osmotic laxatives, which you may be familiar with, polyethylene glycol, otherwise known as Miralax, or magnesium-containing laxatives. They are my favorite because they're the gentlest. So they don't cause a lot of cramping and don't cause a lot of pain. And again, I see so many patients with IBS and with abdominal pain that I don't want to add more insult to injury, right? So stick with the osmotics first. But I also want to acquaint you with the prescriptions because they are a real game changer. And so they are typically just 1 or maximum 2 pills a day, and they really work. So if you feel like you've exhausted all the over-the-counters, then talk to your doctor about getting a prescription laxative because they have really made a dramatic difference in my patients. Last but not least, there are newer technologies. I mean, at Stanford, we offer a vibrating capsule. So the patients will swallow a capsule at night, and then about 8 hours later, as they're sleeping, this capsule will start vibrating down their colon and kind of rotor-rooters out the stool. So it's a wonderful non-pharmacological therapy that's available. It's FDA approved. So it's really great. So moving on to diarrhea, I'm not going to go at length into all the different causes of diarrhea. I want to mention the most common in my DA patients cause of diarrhea is actually constipation. So it's kind of counterintuitive, right? But it's called overflow diarrhea. And in children, it's called oncoparesis, where you're so full of hard stool, the only thing that can come out is the liquid. So overflow is by far more common than just having diarrhea in and of itself. And what I usually do is if I'm not entirely sure patients are constipated or not, is I just get an x-ray. I'm like, okay, just come in to radiology after you pooed for the morning. I want to see if you're still full of stool. And if you are, of course, I'm going to encourage them to encourage patients to take laxatives. I already talked about SIBO, small intestinal bacterial overgrowth, very common cause of SIBO, especially in DM patients because of that slow motility I talked about earlier. So the good news is that SIBO can be safely treated with this special kind of antibiotic. Essentially, any antibiotic works, but I use this special kind of antibiotic because it doesn't have a lot of side effects because it's very minimally absorbed into your bloodstream, called rifaximin. And so studies have shown that it's safe. You can go on it repeatedly if need be. So it's a wonderful agent for SIBO. Just going to throw this out there that there are other causes of diarrhea. They can be a little bit trickier to diagnose without a gastroenterologist involved. So if you really are suffering from severe diarrhea and you're not responding to some of the kind of conventional antidiarrheal therapies like Pepto-Bismol over the counter or Imodium over the counter, then you may want to get some further testing for things like bile acid malabsorption and fat malabsorption. Last but not least, actually, this is not last but not least, I'm sorry. I'm going to touch upon fecal incontinence. What I want to talk about is that it can be from a lot of different things, but what we do appreciate is that there's a lot, it can be a consequence of pelvic floor dysfunction, which is probably one of the most common causes, honestly, but you can also get fecal incontinence because of weak anal sphincters. And so I think everyone should do this. You could even start right now is start some Kegel exercises because we all just get weaker down there as we age. But fecal incontinence can also be a consequence of having untreated diarrhea, right? If you have constant leakage of stool, constant output, then you may be at risk of constant leakage of stool. And again, that overflow, constipation with overflow can be overlooked and as a cause of fecal incontinence. Last but not least, I want to just touch upon IBS some more because I think it's incredibly important to know that there are really great ways to manage this condition. There's diets. So the most common diet is something called the low FODMAP diet, which is essentially low in gluten, lactose, and fructose. Very popular, very helpful because it reduces the amount of gas that's produced in your tract, and that can lead to less pain as a result. I also am a huge fan of peppermint oil. It really helps with pain and spasm associated with IBS. It's a natural remedy that's safe to be on long-term and it's over the counter. So I just want to throw that out there, but I've also listed some other anti-spasm medications that can be helpful for IBS. And also I want to focus a little bit about the gut-brain connection because I didn't really go into that, but of course I talked about how your nervous system plays such a strong role in motility, but your gut and your brain have this really tight link. And so, that's why we have sayings like I have butterflies in my stomach, right? So any kind of stressor can lead to the development of pain and IBS. So to try to modulate or really dampen that gut-brain connection, which may be overactive, thankfully, there are a lot of options. There's even FDA-approved smartphone apps that can provide therapy. At Stanford, we have a GI psychologist that performs gut-directed hypnotherapy. She also does cognitive behavior therapy. So there are a lot of ways that we can manage that. And of course, there's more conventional medications that can be used, such as antidepressants and anti-anxiety medications as well. But I also love acupuncture. I'm not a lot of robust data behind that, but I'm definitely more of, I like more homeopathic remedies. So acupuncture mindfulness can also be helpful. So in conclusion, GI symptoms are very common in those with DM2, and early diagnosis and treatment are important, not only for improving quality of life, but you also want to treat early on such that you prevent complications such as malabsorption and weight loss. So ask your care team for a referral to a gastroenterologist to discuss symptoms further. Thank you so much.